So for drug properties and drug entry, we move from definitions into chemistry and physiology that determine whether a drug can actually get where it needs to go. And this is where our understanding of terms like permeation and absorption, they begin to matter in a very practical way. And that'll kind of be the hallmark of some of the elements as we move forward into this topic. So now we're transitioning into the physicochemical nature of drugs. And drugs are chemicals, and their physical and chemical properties strongly influence how they move through the body and where they distribute and what they bind to, how they're eliminated, or all these factors have to be considered. So this slide organizes that idea into four different areas, which I'm going to go through one by one and discuss some of the different elements. Let's start with the key drug properties. So first, drugs behavior is influenced by several basic properties. And size affects a drug and whether it can pass through channels and pores or barriers. The shape of the drug is also important. It affects whether it fits a receptor or a binding pocket. And the pH or pKa, these influence whether the drug is ionized or unionized, whether changes in absorption or movement across membranes can occur. And then the chemical class matters because lipid soluble water or water soluble or protein like, carbohydrate like drugs, they may distribute differently in the tissues. And finally, physical state, that also matters. Solids and liquids, gases, right? Those are all handled differently. And so, for example, anesthesia, like gases, those are eliminated largely by being breathed off and eliminated. So some of the other elements of real importance here are pH partitioning. And so I want to take just a moment to talk about how the environment around the drug matters. So on the left of this panel, we have blood or interstitial fluid, and it's at about a pH of 7.4. On the right, we have urine, which may be more acidic. Let's say in this example, it's a pH of 6.0. So between them, there's the renal tubular epithelial cells, right? And their lipid membranes. And the key principle here is that uncharged drugs can cross these lipid membranes more easily. Ionized drugs tend to stay in the water-based compartments. And so a weak base, for example, more of the drug may be unionized in the blood. So a weak base allows it to diffuse across the membrane into the urine. Now, what happens is when it diffuses across the membrane into the urine, it reaches an acidic urine environment, and it can gain a proton and become ionized. Now, once ionized, it becomes more water soluble and less able to cross back into the blood. So this is what's called ion trapping, where clinically this matters because we have an amphetamine type drug, right? Amphetamines are weak bases. And when they cross over the lipid membrane into the urine, they acidify. So the urine increases ionization in the urine environment, and that reduces some of the reabsorption that it can cross back into the blood. In other words, now it's sequestered or trapped in the urine, and now it can enhance or increase excretion. And this is a relevant concept in overdose management. Now, there are some other elements of structural changes of the particular drug. So in this third panel, we see small structural changes that can produce very meaningful changes in drug action. So take, for example, amphetamine and methamphetamine. Right? They look very similar, but methamphetamine has an additional methyl group. And that small difference can affect lipid solubility It can affect tissue distribution. It can affect the potency or the duration of action that this medication has. It can affect the interaction with transporters and receptors. And so this is why medicinal chemistry matters. See, a manufacturer might begin with a compound and then make slight structural changes to see whether the drug still interacts as it's supposed to with the intended target, but perhaps now it has different potency, different selectivity with receptors, different duration or side effect profile, right? So how long it's going to have its intended effect. And that kind of leads us right into this last part. And fourth, this is what we see happening where we have this dopamine signaling. And DAT is the dopamine transporter. And normally, dopamine is released into the synaptic cleft, and then it's cleared partly by reuptake through dopamine transporters. So amphetamine and methamphetamine both interact with dopamine transporters. They're DAT substrates, and they competitively inhibit dopamine uptake. So this leaves more dopamine in the synaptic cleft. In other words, less is being cleared out. So methamphetamine generally produces a greater dopamine efflux through this dopamine transporter than does amphetamine. So methamphetamine means it tends to be a more potent and longer lasting impact of dopamine in the system. So the greater dopamine accumulation, especially in terms of these reward pathways, including where it's released the nucleus accumbens, these contribute to reinforcement and addiction risk. See, so we give a methamphetamine drug that increases dopamine staying in the system, thereby creating a more potent effect of the methamphetamine. So the takeaway here is that drug behavior depends on the drug's physicochemical properties. And it also depends on the environment that's around the drug. In addition, it depends on the route of elimination. And so when we think about a medication, we should not only ask what the medication treats, but we should also be asking what kind of chemical is it, where can it go, where can it move, what can it bind to, and how does the body get rid of it? Right? So these are all considerations that have to be accounted for when we're considering some of the elements of the nature of drugs. So let's consider, for instance, so let's go back to kind of part 2 in our understanding up above. Let's say in the case of drug overdose, right? The ER physician recognizes the patient has taken a drug. Now, when we talked about the movement of that drug from the interstitium and blood into the urine, we said, hey, if the urine is more acidic, then it's going to charge this drug with an ion, and it's going to prevent the movement back into the blood. So an ER physician can leverage this understanding and prescribe a different medication to make the urine more acidic. And therefore, the drug is going to stay in the urine so it can be excreted. So let's make this idea practical. Let's take, for instance, minocycline, for example, an acne medication. So a patient comes in and says, hey, I've been using this acne medication for months, and it doesn't seem to be helping, right? One of the first questions that we might want to ask is not only what the prescription drug that they take is, but maybe what other things they're taking, over-the-counter products, vitamins, supplements, herbal products. And in this example, something as simple as taking antacids like Tums can completely change the body environment. In fact, enough to impair absorption. So the point here is a good medication history includes not just prescription medications, but over-the-counter products, vitamins, minerals, herbal treatments, because all of these things may be affecting the outcome. And so in the example where we have the patient who's talking about taking the minocycline but also taking Tums, you see in panel 4 there, the clinician says, well, that might be your problem, because what's happening is Tums is changing the pH of the stomach. Now, previously we talked about urine sequestering and keeping the medication there, but now we're talking about a different area. So Tums is changing the pH of the stomach, and what it's doing now is it's preventing the medicine from being absorbed. And this again is creating a challenge. So make sure when we ask medication history, it's not a focus on prescription drugs, because this is what patients are going to think when they think medication history. But it's everything. Legally prescribed drugs, vitamins, minerals, over-the-counter supplements, herbal treatments, all of the above. And this figure extends the acid-base discussion into elimination. And so previously we discussed, right, urine pH can change how quickly certain drugs are excreted. For example, if urine becomes more acidic, some drugs, including methamphetamine, may be excreted more rapidly. And the broader lesson here is that pH matters at more than one point in the process. So as we discussed, it matters at absorption. And it also matters later at elimination, which means the body's chemical environment can influence how long a drug stays active. So how do drugs actually get in? In the picture here, we're looking at the lining of the stomach. And there are actually several possibilities. For instance, some small substances can move straight through the cellular junctions. Hydrophobic drugs may pass right through the phospholipid membrane. And some drugs are going to rely on transport proteins, where others are going to enter through processes such as endocytosis, where the body actually forms a cell membrane around the drug and moves it in. Now, all of these matter clinically because the body can upregulate transporters that move drugs out of cells. In cancer care, for example, a drug may stop working partly because the body is maybe becoming more efficient at pumping it away from the target tissue. So muscle, fat, oral routes of administration, right, all of these play a key role in how drugs get into the system. And this slide gives us a broader pharmacokinetic map of what happens after an oral dose. So the pill is taken and it enters into the stomach or intestine and it's absorbed. And it may pass through membranes, it reaches the liver through the portal circulation, and only then does it reach the systemic circulation in a form that can actually affect the target organ. So along the way, there's several barriers that can interfere with the effect. So sometimes a medication, even when activated in the liver, as in the case of codeine being converted to morphine. And for certain drugs, barriers like the blood-brain barrier, those become especially important when the target tissue is difficult to reach. So if you remember one thing from this segment, let it be this. A drug cannot work unless it can get in, unless it can be absorbed, and it reaches a meaningful concentration at its target tissue. So the chemistry of the drug and the environment of the body, they're both shaping and altering the process from the very beginning. So I'll just close with a couple of examples here. For instance, we mentioned you orally take a medication and the drug makes its way into the stomach where it's absorbed. Well, then this is where the first pass effect comes into play. So sometimes a medication is not actually active until it makes its way through the liver. So this is where codeine, which is a pain medication, does nothing in the body until it's actually converted to morphine in the liver. Now, separately, we also need to understand some of the important elements of the target organ. Some drugs activate receptors more than others. And so a drug gets to the target organ, and then it has to have enough concentration to the point where it actually elicits an intended effect. So to give you an example, Prozac, which is a medication for depression, may take nearly a month until it has its beneficial effect, until it's built up enough in the body. So the patient needs to be aware that the medication may take a while to work.